but our staff who've all worked so very hard on this program, our planning committee, Mark Johnson in our office, Barbara Giles, she's the person you see outside to fill out your little slips for the door prizes, Joe Zapata, and from the VA, Elizabeth Packer, Veronica Salazar, and Tressa Carr. And in the back of the room, we have a stream team. This conference and tomorrow's conference are being streamed live on the internet to other folks who are listening in who couldn't be here. And that team's led by Bob Merrill, and back there with him as well are John Munoz and Kelvin Buchanan. So thanks to them. And do you want to do? Okay. So
we have some lost and found announcements for everybody. If anyone has lost a pair of glasses, come on up to the front table later and we'll hand it over to you.
And if you can't see to come up here, just raise your hand.
He's so clever. And if anyone has lost a little key catcher thing from your purse, we've got that. And then there's also a black sweater that someone left yesterday. So if you were here yesterday and you left your black sweater, don't come to us because we don't have it.
And at the end of the day, if these are unclaimed, there'll be door prizes.
Okay, and is there anything else we were supposed to remind them about? Okay, all right, Dr. Parker.
I'm on. Good. Dr. Yee is working this afternoon in the ACE unit and called me this morning that said she was just so busy and she had 2 family conferences this afternoon and asked if I would give her a presentation. So I looked at these slides about 3 or 4 hours ago for the first time. So I happen to know this project because I mentored her through it. She had a Geriatric Academic Career Award, which is a really big honor, and Dr. Oakes also received one. And it funded one of her research projects, which was implementing the Interact II program. Has anybody heard of Interact II? Hold up your hand? No? So I need to explain that. You didn't hold up your hand, Maria. Okay. Maria has heard of it. So that's a picture of our campus, which is changing. Now there's nothing but cranes out there. Briefly, the Interact program was conceived by Dr. Joe Auslander, who's a professor of geriatrics at the University of Florida Atlantic, I think they call it, or Atlantic, Florida. It's a new medical school. And he got a big grant to implement this, and this is part of a pilot project in about, I think, 10 other cities. And the implementation was meant to reduce unnecessary transfers from nursing homes. Now, the way it works in most places is things always happen at night. You know, things go bump in the night, and they always get bad after the change of shift at 11 o'clock. And then they call the doctor at 1 o'clock in the morning, and they wake you up, and you can just barely put 2 and 2 together, and they say, Mrs. Jones is yelling and screaming and ripping her clothes off and doing all sorts of things and calling me nasty names. So we usually just say, oh, just send her to the emergency room. And that's what happens. It's the easiest thing to do. We don't, and often the guy that's taking the call doesn't even know the patient. So maybe it is the safest thing to do. And it solves 2 problems. It gets the nurse off the phone, and the nurse doesn't have a problem because it gets the patient out of her institution. The patient has got the problem. So this is what Dr. Auslander wanted to do. So we want to understand what some of these challenges are to implement this, understand the tools that are associated with it. We'll talk about how we reduced the inappropriate transfers in some of our nursing homes. And we'll talk about some of the future implications. This is an article that was published in in New England Journal in 2009 by Stephen Jinks about re-hospitalization among patients in the Medicare fee-for-service system. And you all are probably familiar with that. You saw this slide earlier from the same article. We have a 19.4% readmission rate in Texas. Now, we're not the worst. We always have Louisiana and Mississippi to compare to. They're terrible. We're much better. So, patients commonly experience multiple transitions. And this is just amazing to me. I mean, they're traveling around sometimes, I think, more than I do. This little pie chart shows that most people have one or less movement after hospital discharge. But 18% will have 2 more transfers, 9% will have 3 more, 4% will have 4 more. These are the people that are really at risk, because every time you make a transfer or transition of care, it's an opportunity to screw up again. And an opportunity for your frail elder to get delirium. And delirium is a serious condition. It has a fairly high mortality rate. So, challenges, fiscal pressures to decrease hospital length of stay. We've got, when the DRGs first came in, we used to have people meet us at the front door when the doctor walked in. Some of the doctors will remember this, and they'll say, well, how long are you going to keep Mrs. Jones? Until she's better. They want to know, what day can you discharge her? Lack of healthcare continuity we've talked about, complexity of elders. All older folks are complex. Even if they only have one disease, all their organ systems have used up all their reserve capacity. So it doesn't take much to push that first domino over, and the whole chain starts falling down. Nobody knows what drugs these patients are taking, not even the patient. We don't use our community resources. We've talked about this, communication, availability discharge summary. So the Interact program really is about 3 domains: the information domain, educational domain, and the destination on both sides of the transfer. So in the informational domain, we want to have a common method of communicating medication lists. We want a way to accurately document what's going on with the patient during the transition. And we want those advanced directives. We're terrible at advanced directives, still. We want to educate everybody on the healthcare team, both on the receiving end and the sending end, about what the continuum of care is all about. What is the relationship to the other services, physical therapy, speech therapy, wound care management? What is the treatment plan? Focus on the evidence. And there's a lot of regulations involved here too that we need to know about. This slide, I kind of like that she chose this. This scale shows the patient's health from end of life to robust health, chronic disease, multiple chronic diseases, frail, disabled, dependent, and end of life. And on this axis, we're seeing the level of care, outpatient, inpatient. Chronic diseases is more ambulatory and acute hospital. Multiple chronic diseases seem to focus in the ACE unit. The frail, we do geriatric assessment. We have geriatric rehab, post-acute care. Disabled are in the same category. As they reach complete dependency and end of life, nursing home care, we do house calls, palliative care, and PACE programs, which we don't have one. I don't think we've got one in San Antonio. Do we have a PACE program? I don't think, I've not heard of one. So Interact is an acronym for Intervention to Reduce Avoidable Acute Care Transfer. This website will take you to the entire Interact program. Since it was funded by AHRQ, a government agency, it's free. You can download the whole thing, use it in your institution. It's got all the tools, everything you need to implement it. And a lot of people have done it. A lot of institutions have done Interact just with this information. I already said that. Communication tools. This is, I think, is probably one of the big secrets, and it's very similar to what we're doing on the ACE unit. You're empowering the CNA and everybody on the staff really to make observations about the patient and make some decisions. So we have early warning systems. It's a little card called Stop and Watch. So they can, in their daily activities, they can stop and see what that patient's really doing. Has anybody implemented Interact in their institution here? Yeah. Are you using all the tools? And it's a continuous process of education because we have such a high turnover in long-term care. But you really need to keep doing that. And the SBAR, and I think we've got some video clips I'll show you of what they do with the SBAR. But it's a way of communicating for the nurse to communicate with the doctor, so the doctor doesn't just say, oh, send them right to the emergency room. It utilizes, the program also uses the American Medical Directors Association guidelines for care pathways. I'm not going to go into a lot of detail about that. We look at and address the hospital transfer forms. We have a checklist. Everything that the hospital is going to need when they have to go, if they have to go. This is the SBAR form that we use to train the nurses. After they've used it many, many times, they don't need it. But it's just a way to sort of a checklist, really. So before you call the doctor, they do the evaluation, they check the vital signs, get the chart, the medication list. Nothing worse than trying to figure out what's going on with the patient when the nurse calls and you say, well, what was the blood pressure? What was the temperature? Oh, just a minute. Well, what medicine's he on? Oh, hang on a second. I'll just send him to the emergency room. So what is the situation? What are the exact signs and symptoms? When did it start? What's the background? What is the patient in the nursing home for? What's the diagnosis? What are the vital signs? What is the change in function? Give me some detail. And then assessment. What do you think is going on? You don't have to make a diagnosis, but just tell me what you think is going on. And then request. It's sort of like, it's not a diagnosis or an order, it's saying, I suggest that that you just take a look at them tomorrow, or that we do this lab work or an EKG, or that we stop a medication, or call the family, or whatever. Send them to the emergency room if that's ultimately the reason. But there's some thought process that goes into this interaction. You know how to do that? There you go. There we go.
I use SBAR when I'm communicating with my colleagues. I use it to frame my conversation. I'll say, here's the situation, here's the background, here's my assessment. I recommend that we do the following. Depending on the situation, I'll go into more or less detail. The one thing I've found by using SBAR is that physicians appreciate the way I structure my conversations with them. They know what to expect and generally don't interrupt me as much because they know what's coming next. I really use it all the time, and it's just become second nature to me.
All right. But this particular website does have some other video clips about it that you can use to train your staff and colleagues. this is just a little bit about the transfer form. It has the primary diagnosis, acute and appropriate medication list, the advanced directives, pending tests if there are any, and contact information, follow-up appointment. This is actually the, whoops. This is actually sort of a short version of the checklist we use for our discharge summary in the hospital. So in the nursing home, we implement, with Interact, we're using a care path checklist to reduce common causes of acute transfers. An acute change, and we have care pathways to look at this. Acute change in mental status, fever, dehydration, urinary tract infection, pneumonia or lower respiratory infection, and congestive heart failure, some of the most common reasons that patients are transferred to the hospital. SBAR is used for the template for reporting the condition, and then we use the care pathways from AMDA in the Interact. We've trained every body that works in the facility and the families as they come in about Interact. We use all of the advanced care planning tools, which are actually quite extensive. We keep tweaking the protocols. We have a weekly interactive meeting, interdisciplinary team meeting, just like we do in the ACE unit, about each patient. And we discuss a training on the ACE unit, on the Interact tools while we're in there. The quality improvement tools, we have an acute transfer log so that we can go back later and look at each case about why this patient was transferred. Did we think it was appropriate? Was there something we could have done to prevent that? And so on. Quality improvement tools are used to review all of the acute care transfers, and we use that same log for measuring our hospitalization rates. So as part of her project, she used this protocol, and the process was reviewing a lot of charts for baseline data. Then she put this interdisciplinary team together at the 2 nursing homes that we implemented it, and brainstormed with her team, used the fishbone diagram to look at the root causes. Then the core team members attended the live distance learning curriculum over a 6-month period. And this was about once every 2 weeks for about an hour. They had an interactive curriculum that was more like a webinar, but you could talk to them. And then we looked at the acute care transfer cases and reviewed and discussed each of them at the weekly team meeting. And we measured the transfer rates with a denominator of 1,000 bed days. So re-hospitalization diagnoses, the top diagnoses, a little hard to follow here, but the 11% was GI, 14%, I don't think I'm colorblind, but where is it? 14% for what? Neurologic. Probably, change in mental status. 16% were UTIs, 17% were pulmonary, and the rest were relatively smaller slices of the pie. Pretty much what the care process, the care pathway tools are oriented for. This is a picture of our interdisciplinary team. That's Dr. Yi, who we've got working today. Missed a very nice lunch. But the team is similar to the team that we have in the ACE unit. We have a physician, nurse practitioner, physical therapist, OT, speech therapy, social worker, pharmacist, chaplain. This is the fishbone diagram that she used for causes of avoidable nursing home transfers, hospital factors, nursing home factors, communication, advanced planning factors. That's a big issue, as you all know. Physician factors, we're probably the major source of the problem, and patient's family. Patient's family want their loved one to go to the hospital because they're going to get better care. Right. Yeah, send grandma to the hospital. They'll fix her up. So we prioritized a list of changes. Nursing home admission coordinator provided a checklist to the admitting hospitals, and we screen them pretty carefully to make sure we're getting a patient that's not unstable, that's going to turn around and go right back, which is a common problem, as you all know. We looked and carefully instructed our infrastructure, the staff. We worked with the communication sector for all of our care providers, including the doctors, about the SBAR. The doctors were the hardest people to teach because they want everything just like that, and they don't want to, you know, just skip all that. Don't tell me all that stuff. Just tell me what you want. What do you want me to do? So we've got them so that they'll listen to the nursing staff when they call, for the most part. It's always an outlier. Advanced care planning, real important. Why are we transferring people that are DNRs, that are end of life, to the hospital? Just because the family wants that. Why do we do that? And many of them haven't really finished their advanced care planning anyway, so let's get on that when they get admitted. So results, this is the acute transfers before and during the Interact intermissions. From March through August of 2010 compared to March through August of 2011, we went from 4.72 transfers per 1,000 bed days to 3.69 transfers per 1,000 bed days. And that's actually a significant reduction. It's a 21% absolute reduction of all causes for 30-day transfers. That correlated to about 37 transfers per year for this particular nursing home, which doesn't sound like a lot, but if you add up how much money it saves, 37 fewer re-hospitalizations, average DRG payment per hospitalization, $6,500, we saved Uncle $240,000. Uncle likes that. So he's going to do more of it, probably. He's funding this program to be spread out to other institutions. So it's going to be appearing in other nursing homes across the country. What did we learn? Or what did Dr. Yee learn? She learned that it's hard to build a good quality improvement team and keep them on task. And you have to keep them inspired. You have to keep giving them the data to show that they are making a difference. It's that recognition of making a difference that really makes these people want to go on. They don't get paid more or less if you do a good job. So you have to think of a better reason. Think about it in terms of the process rather than finger pointing and blaming. What went wrong with the process? What went right with the process? How can we change that process if we need to? How do you define a preventable transfer? Sort of like trying to define an observation from an inpatient, you know, it's sort of an arbitrary thing. Maybe it's in the eye of the beholder, but we need to try to make that definition clear. And that's what she learned, was that by trying to get to a commonly agreed upon definition of what is avoidable and what's not, it really improved the intervention strategies and the use of these tools. We still have trouble getting people to use the tools. And again, that's a variety of reasons, not the least of which is turnover. I think most nursing homes have a turnover of 50 to 100% per year. CNAs are the most underpaid people in the world. I couldn't do what they do. I wouldn't do what they do. They're saints, and yet we pay them hardly anything. Wonder what would happen if we paid them what they're worth. Yeah. What is the next step? Well, we're going to keep working on teaching our physicians. The next generation is a little more teachable. Some folks just don't change. I'm an old guy that learned, though. Even though they don't stand up for me anymore. We keep reinforcing the standardized protocols and approaches as the care pathways are needed. And the care pathways you'll find on the website are quite elaborate, and they're relatively easy to follow. And the nurses love them. And these are the interventions that you can do to prevent a hospitalization. Increased awareness to complete comprehensive end-of-life care. Are all of you familiar with POLST, P-O-L-S-T? Google it. It's a wonderful program. And we ought to be doing that with all of our residents who are at increased risk. Review transfers and data collection routinely with your staff. Keep it in front of them. And again, post your results in public. Teach patients and families on the goals of care and the transfer process. They need to know, families need to know that going to the hospital isn't the best thing, always. In fact, it usually isn't, and that many people get worse in the hospital. But we can treat a lot of things in the nursing home now that we couldn't do before. So in the future, she wants to incorporate the emergency department in preventing hospitalizations. And one of the other doctors was describing this problem to me earlier, and once an old person comes to the emergency room, they all seem to get admitted. So how do we teach emergency department doctors to take care of frail elders and recognize which ones need to be in or not? They don't do a geriatric rotation. They don't have any geriatric training. And I keep telling people that geriatrics is just as different from internal medicine as pediatrics. We get different diseases. We react to medications differently. And the outcome is different. Our goals are different. And we didn't used to live this long just 30, 40 years ago. I mean, you didn't see, the fastest growing segment of our society now is those over age 85. Wow. We've never been here before. So why should we know how to take care of them? We haven't trained our doctors to do that. And even though it's recognized as a specialty since 1988, it really hasn't been accepted by the medical community or even by my university as a specialty because it's not required for training residents or faculty or medical students. So we need to incorporate this into our training for everybody. Incentives are coming for the hospitals. There are some already here, and they're going to be working proactively with the nursing home. They may actually be partnering with the nursing homes as the ACOs are developed. Accountable care organizations, vertically integrated financial partnerships, where they can actually work with the nursing home and have a program where they can send their patients there and they know they're not going to get readmitted unnecessarily. So a nursing home that's got a better track record and can show the data is going to have a better opportunity to partner with a large hospital system. We're trying to teach the hospitalists right now, and I think we need to incorporate that in their training also, but we need to do it as an ongoing process now for the people we already have. Long-term care staff need to address potentially preventable hospitalizations. I think she means by that that the entire staff needs to be looking at this. You have to have buy-in from the top down, including the owners of the nursing home chain. And a lot of times that's where the problem lies because the financial incentive may be a little bit different. But I think as they find that building quality and demonstrating that is going to improve their ability to sell their institution, that they will do this for the right reason. money. Blah, blah, blah. References. Joe Auslander. If you ever get a chance to meet him, he loves to talk about this. This thing's just worn him slick. It's been so successful, and it's sort of taken over his life. But he was a mentor for Dr. Yi also, and worked with her on this award that she received. And it's been a great program. The two institutions we've implemented in are still using it and still tweaking it. And I think the hardest thing is to keep it going. With any quality improvement project, that ultimately is the hardest thing. How do you keep the process going? Whether you're Toyota and making a good car, I mean, Toyota's had some problems recently, haven't they? What happened? They quit using their tools, or they weren't implementing them consistently. So if we're going to continue to improve, we have to figure out a way to maintain the gain on a consistent basis. And I think we really do that by keeping the numbers right in front of our staff at the lowest level, at the front line, about how good a job are we really doing with pressure ulcers? How good are we doing with urinary tract infections? How good are we doing with Foley's? I ought to be able to walk up to anybody in your institution and ask them, and they ought to be able to tell me. Most of us can't. Even the administrators can't. And that's the end of Dr. Yi's talk.